and HAE type 2 being dysfunctional C1 inhibitor. And then there's HAE with normal C1, and these patients have normal C1 inhibitor, as evidenced by the name. Acute attacks have a variable onset. The majority will gradually develop over hours, but they can occur in different temporal time frames. They can be prolonged with increasing intensity over 24 hours and usually resolve in 2 to 4 days. Another hallmark is that these acute attacks are unresponsive to antihistamines, corticosteroids, or epinephrine. They are, again, unpredictable, and they have varying frequency, and the triggers can vary not only between patients, but also within the same patient. Commonly affected areas for HAE, again, as I mentioned, face, extremities, and genitals, the oropharynx, and the gastrointestinal tract. First symptoms can occur in childhood or adolescence or even later in life, and common triggers, again, can be variable, and they include trauma, such as surgery, dental procedures, emotional stress, estrogens, including oral contraceptives, and pregnancy. So the pathogenesis of HAE can be seen here on this schematic. In the classical complement pathway, the complement protease C1 is activated and then assembles the C3 convertase. You can see the activation is indicated by the horizontal bars over the complement names. And in the contact activation pathway, trace amounts of factor 12A activate additional factor 12, as well as prekallikrein. Activated factor 12A then activates factor 11 to factor 11A, leading to enhanced fibrin formation. And activated factor 12A and kallikrein activate one another, and then plasma kallikrein cleaves high molecular weight kinagen to release bradykinin. In the fibrinolytic pathway, plasminogen is activated to plasmin, which cleaves fibrin. And the proteolytic activities are indicated by the green arrows on the slide, and they point towards the steps that they then catalyze. The central defect in hereditary angioedema is a deficiency or dysfunction of C1 esterase inhibitor, as I mentioned. This leads to uncontrolled activation of the contact system and increased bradykinin, a potent vasodilator responsible for the swelling. I think we all remember these kind of slides from medical school. Another important distinction is mast cell versus bradykinin-mediated angioedema. HAE, again, as I mentioned, is bradykinin-mediated, which explains why it doesn't respond to traditional allergy medications like antihistamines and steroids. Recognizing this distinction can prevent treatment delays and unnecessary interventions, as well as delayed diagnosis, which a lot of the hereditary angioedema patients face, and sometimes it can take years for them to get a proper diagnosis. So HAE is classified into 3 main types, as I mentioned. Here is just a nice showing of this, looking at the C1 inhibitor deficiency, type 1, low C1 inhibitor levels. This is due to the SERPINE1 mutation, and that can be also seen in the C1 inhibitor HAE type 2, which is when you have the dysfunction of C1 inhibitor. Then we have normal C1 inhibitor, and this one is the more complicated one because for a long time, we didn't know the genetic mutations, and now we have identified more than 6 of these, and even more are being identified, including factor 12 mutation, plasminogen mutation, angiopoietin, kininogen 1, MyoF, and others are listed here as well. But classification is important because it guides diagnostic workup, as well as helping us with treatment selection for our patients. So now we're going to switch gears and talk a little bit about when to suspect hereditary angioedema. So HAE should be suspected in patients with recurrent angioedema, especially when you don't see that urticaria. It doesn't respond to antihistamines or steroids, and it is accompanied by abdominal pain or involvement of the upper airway. There's some important clues to think about if a patient comes to you with swelling. 25% of patients may have no family history, even though I mentioned that it is autosomal dominant. Onset, again, as I mentioned, is typically in childhood or adolescence, painful and recurrent abdominal symptoms with no other cause, upper airway edema, and then again, I will repeat it again and again, no response to antihistamines, steroids, epinephrine, or omalizumab. Many patients will describe prodrome symptoms before swelling. They'll feel a weird tingling. They may feel a dysphoria. They may feel dizzy. This again can vary between patients and within the same patient, but patients will describe knowing that they may be about to start to swell. And again, no wheals, no urticaria should prompt us to be thinking about bradykinin-induced angioedema. So the diagnostic workup in patients with suspected HAE is to first of all have that high index of suspicion for HAE with some of the clues that we discussed on the previous slide. The first line diagnostic approach includes the C4 level, the C1 inhibitor antigenic level, as well as C1 inhibitor function. And these assays are listed there for you. If any of these are abnormal, C4, C1 inhibitor, or C1 function, then you would want to confirm with repeat testing. And if that repeat testing confirms, then you have your diagnosis. If these are normal, then you may, and you still have a high index of suspicion, you would want to consider genetic testing, screening for those mutations that I reviewed that are associated with hereditary angioedema with normal C1 inhibitor. But it's very important to have a structured workup, again, for timely diagnosis and appropriate classifications so patients do not have delay to proper treatment. This is a typical diagnostic laboratory profile for both HAE1 and HAE2. Both types will typically have a low C4 level, so that's often used as the first screening test. Type 1 shows reduced C1 inhibitor levels and function, while type 2 can have normal or even high C1 inhibitor levels with reduced function. But these patterns help differentiate between the types and, again, guide therapy selection. Not only important for board exams. So genetic testing can confirm the diagnosis of hereditary angioedema. And again, it is used primarily for confirming once the other screening tests have been done, or in cases with inconclusive labs, as I mentioned. It's not really a frontline test for type 1 or type 2 because of the availability of cost-effective tests that I just reviewed with you. Genetic tests can be very expensive, but they may identify pathogenic variants like SERPINE1 or F12. What about family screening? So we get questions on this a lot. All first-degree relatives of patients with hereditary angioedema should be screened. And this is 100% expert agreement on the panel of folks who came up with the World Allergy Organization and European Allergy Asthma International Guidelines. So this is an evidence level of D. And why is it important? Again, delayed diagnosis can increase morbidity, decrease quality of life, and delay appropriate therapy. The first hereditary angioedema attack may affect the airway, which can be life-threatening. It can also be in the abdomen. So we want patients to obviously not have asphyxiation, but also some of these patients may undergo unnecessary surgeries, even exploratory laparotomies due to their recurrent abdominal pain. So important to diagnose these patients correctly. Again, who should be screened? Everyone, grandparents, parents, siblings, children, and grandchildren. And again, C1 inhibitor function levels and C1 inhibitor protein levels, as well as function and those C4 plasma levels. And then upon diagnosis, on-demand therapy should be prescribed immediately. And it should be available for the first attack as well as for future attacks, even if no attacks have occurred yet. So again, this is why we do family screening, so we can catch it before the patient even experiences their first attack of HAE. What about reducing HAE burden on patients and caregivers? We all hear a lot now about caregiver fatigue, and it is certainly real in all rare and chronic diseases, but it's typically burdensome in hereditary angioedema. So the total disease burden can really be thought of as this cartoon depicts: an attack, then quality of life disruption, another attack, another quality of life disruption, and the cycle seems to be sort of never ending for these patients. They can live with the constant fear of unpredictable swelling episodes, which can not only be disfiguring and uncomfortable, they can also be life-threatening, as I mentioned, but they can also severely impact quality of life, whether that's on work, school, or just normal daily activities. Emotional distress, anxiety, there can be isolation. These are common symptoms that are described by patients with hereditary edema, and especially in those who have frequent attacks or laryngeal involvement. I mean, the fear of perhaps having a laryngeal attack and having a fatal outcome is very real in these patients as well as in their caregivers. So thinking about caregiver burden in HAE, the HAE impact does extend beyond patients, affecting not only direct caregivers, but also more indirect support networks as well. The caregivers often will take on the responsibility of monitoring the symptoms, managing the medications, handling the emergencies to take some of the burden away from the patient, or if the patient is a pediatric patient, for example. And you can see here the HAE-related tasks performed by caregivers on the left-hand side of the slide. And some of these, again, are managing medications, handling emergencies, knowing which emergency rooms are better to go to than others. And it can be coordinating care, helping with the emotional toll, and then any limitations that not only the patient has in their work, but what about the limitations they may have in their own work or social lives because they are taking care of the patient. So as we consider shared decision-making, it's really vital to include the caregiver perspective in the discussion. Obviously, the final decision for treatment would be between the patient and the healthcare provider, but it is very important to have the caregiver give perspective as well. So assessing disease control, there is a patient-reported validated outcome test called the Angioedema Control Test, AECT. And it has the following questions. In the last 4 weeks, how often have you had angioedema? How much has your quality of life been affected by angioedema? How much has the unpredictability of your angioedema bothered you? And how well has your angioedema been controlled by your therapy? And so you can see that this is used to gauge the frequency, impact, emotional burden, as well as the perceived treatment effectiveness and burden among patients. And you can see the scoring there, and a score below 10 would indicate poorly controlled disease and should really prompt a reevaluation of the current management plan. So this isn't a perfect tool, but it is a quick and practical way to engage patients and help them quantify their responses to therapy over time, because sometimes it's difficult for them to really be able to verbalize some of the answers to this if it's just free questions. So this, again, patient-reported outcome is a really good and practical test. So what about trigger avoidance? I had mentioned that there's a lot of different triggers and they can vary between patients and even among the same patient. So identifying and avoiding known triggers can help reduce attack frequency and improve overall quality of life. And that can be even managing positive or negative emotions, trying to avoid getting an infection, whether that's just the common cold or the flu or other viral infections or any other infections. Minor trauma to severe trauma, so even as much as stubbing their toe, trying to modify life to try to avoid those minor traumas. Fatigue, patients who aren't getting good sleep or working third shift often can have attacks due to their fatigue. Medical and dental procedures, that's a time to coordinate care between the HAE provider, the patient, the caregiver, and whoever is going to be performing any dental procedures or medical or surgical procedures. And of course, hormones is a big conversation because, as I mentioned, estrogen can be a big trigger. So trigger avoidance is very important, and it really complements the pharmacologic strategies that we use in patients with HAE, and again, can reduce not only attack frequency, but also the severity as well. Now we're going to get into a little bit about the treatment of hereditary angioedema. So some of the general treatment strategies for hereditary angioedema really are to use on-demand therapy, short-term prophylaxis, and then long-term prophylaxis. So when we're talking about on-demand therapy, this is to rapidly stop an attack at the onset before any morbidity or mortality ensues. This is, according to the guidelines, required for all patients that they have enough medication on hand to treat 2 or more attacks. And patients are encouraged to treat every attack at the first sign of having one. Short-term prophylaxis is to prevent attacks for those at increased risks with known triggers. So somebody who's had dental work and has had an angioedema attack and is going in for another dental procedure, or someone who's having a scheduled medical procedure that is known to cause angioedema. This is also called situational prophylaxis, but short-term prophylaxis is the more preferred term. Long-term prophylaxis is to reduce disease burden long-term, decreasing attack frequency and severity chronically. This is individualized when this is initiated and which treatment is initiated. And again, shared decision-making for all of this is very important, again, for the patient as well as the caregiver. And honestly, it needs to be individualized. This way, each patient has optimal care for them and their own individual quality of life is normalized. There really isn't a one-size-fits-all. So again, according to the U.S.A. Medical Advisory Board 2020 guidelines for the management of hereditary angioedema, all patients should have on-demand access and prophylaxis should be considered based on disease frequency, severity, as well as patient preference. And it's also very important that both the choice of the agent and the route of administration should be highly personalized to help reduce disease impact on patient quality of life. Adjusting those first-line therapies based on age is important to remember, and avoiding exogenous estrogens, using C1 inhibitor during pregnancy and breastfeeding. Also, when we're thinking about prophylaxis, considering progestins and antifibrinolytics for C1 inhibitor with normal type 3, as it used to be called, but HAE normal C1, there is limited evidence for this, but again, shared decision-making would be employed at this time. And again, these are the guidelines from 2020, ensuring all patients have access to on-demand therapy, providing prophylaxis, and individualized and regularly adjusting management plans. So this is just looking at the history of FDA approvals for hereditary angioedema. And this is really historical perspective. This timeline shows how FDA-approved treatments have evolved for hereditary angioedema. And it's been a really exciting time to take care of patients with HAE. I remember writing my first C1 inhibitor prescription back when we were still using prescription pads, and I wrote it on a prescription pad, and my hand was shaking, thinking about how exciting it was, but also how expensive it was. And so starting with intravenous plasma-derived C1 inhibitor, that was in 2008, a long time ago. I've aged myself. The treatment landscape has progressed from IV to include subcutaneous, recombinant, monoclonal antibody, as well as oral therapies. And the development of novel therapies is expanded to include patient choice, and again, enabling those less burdensome treatment plans, thinking about the patient individually. So on-demand therapies for hereditary angioedema. Again, acute HAE attacks require prompt on-demand treatment to reduce morbidity and the risk of asphyxiation and a bad outcome. So when we look at this cartoon, we can see the available on-demand treatments target different points in the bradykinin pathway. Icatibant blocks the bradykinin B2 receptor, preventing bradykinin from causing that vascular leakage, which leads to the swelling. Ecallantide inhibits plasma kallikrein, reducing bradykinin production. And then C1 inhibitor replacement, whether it's human or recombinant, restores the deficient or dysfunctional C1 inhibitor, addressing that root cause of excessive kallikrein activation. So now we're going to look a little bit more closely at the evidence to support these therapies. So this was one of the first studies to evaluate on-demand treatment for hereditary angioedema. And again, you can see this was published in 2009. And this was Craig and other authors. And it demonstrated that symptom relief was achieved significantly faster with C1 inhibitor versus placebo. And interesting to note is the favorable safety profile. There were no seroconversions. There was no transmission of bloodborne viruses. And this was a big concern at that time. And so this study really showed that this was a safe treatment and also effective. And C1 inhibitor remains trusted and a widely used option for on-demand treatment. I use it in my patients. This was Edema 3, which was looking at on-demand treatment of HAE with ecallantide. And you can see that this trial is showing that ecallantide effectively reduced symptom severity compared to placebo. And it's important to note that the key endpoints were the TOS, or the treatment outcome score, as well as the MSCS, the mean symptom complex severity. And you can see marked reductions in those with ecallantide compared to placebo. Again, there were no treatment-related serious adverse events in the edema-3 trial, and there were no deaths. So again, a safe and effective treatment for on-demand treatment of HAE with ecallantide. FAST-3 was the study that looked at icatibant for on-demand treatment of HAE. This provided faster symptom relief than placebo in non-laryngeal HAE attacks. You can see here the median time to onset of symptom relief with icatibant is the red and the placebo being gray. Now, injection site reactions were common, but these were mild and self-limiting and not really unexpected. And again, incidence of AEs was similar in both groups. So this was also reassuring. Icatibant offers a self-administered subcutaneous option, which is beneficial for patients who want to maintain their independence. The CONFIDENT trial, looking at sebetralstat for on-demand treatment of HAE. This is an oral plasma kallikrein inhibitor for acute HAE attacks. The study here, as you can see from the results, demonstrated faster onset of symptom relief, significant reduction in attack severity, rapid complete resolution of attacks, as well as a favorable safety profile. This was very recently FDA approved as the first oral option for treating hereditary angioedema attacks. So the first oral on-demand treatment. And again, similar safety profiles between the active arm and the placebo arm here, and no SAEs related to the trial agents were reported. So now we're going to shift gears and talk about prophylactic therapies for hereditary angioedema, looking a little bit at mechanism of action. Again, the therapeutic advancements to long-term prevention have enabled reduction of attack frequency and severity. And again, it's been an exciting disease to be involved with, given how much development has occurred in really a short amount of time. So looking at this, you can see C1 inhibitor replacement therapy. You can see that's restoring the baseline inhibitor levels. And then lanadelumab is a monoclonal antibody inhibiting plasma kallikrein. And then berotralstat, the first oral kallikrein inhibitor for prophylaxis. Again, we want to employ shared decision-making, even when we're talking about prophylaxis, when to start it, which agent a patient may prefer, whether that's how it works or safety or efficacy, frequency of attacks, and how much the quality of life is affected. So looking at the COMPACT trial, which was in the New England Journal of Medicine in 2017, this was looking at HAE prophylaxis with subcutaneous C1 inhibitor. And you can see here that this demonstrated a significant reduction in attack frequency with the subcutaneous C1 inhibitor versus placebo. Local site reactions were the most commonly reported AEs, but generally mild. And it's very convenient for patients to have a subcutaneous option available to them that they can self-administer. So again, a point to make when you're employing shared decision-making. The HELP trial, this was published in 2018 in JAMA. This was looking at lanadelumab for the prophylaxis of HAE. So again, you can see the substantial reduction in HAE attack rates with lanadelumab. Again, injection site reactions, not unexpected. They were the more frequently reported with lanadelumab. These were also considered to be manageable. Dizziness was also reported more frequently in the lanadelumab-treated patients, but it does offer a very targeted biologic option with infrequent dosing. So this is an option that many patients will choose due to the every 4-week dosing and the AE profile as well. APEX-2 from 2021 confirmed the efficacy of daily oral berotralstat for preventing HAE attacks. Again, this is common AEs were mild, In this case, they included GI symptoms, which not really unexpected with an oral agent. But again, important to point out, no serious treatment-related AEs were observed. And these are the reason I'm mentioning so many of these is because it's part of the conversation you're going to want to have with your patient. And it also shows you how the FDA chose to approve all of these products, looking at the efficacy and safety, of course. So it is, this was also very groundbreaking as the first oral prophylactic option for patients. And some patients who have needle phobia and want to avoid injections would prefer this over an injection. So Vanguard, this was evaluating garadacimab, a monoclonal antibody targeting factor 12A, which we saw in the cartoon is an upstream trigger in the bradykinin cascade. So this was a novel mechanism of action. And as you can see here, with garadacimab, there were fewer monthly attacks over the 6-month study period. There was very good tolerability, and factor 12 inhibition did not increase bleeding risk, which was a concern given the pathways that I reviewed earlier. And this was a major concern when this first was being studied, but it did not show to be true. So very reassuring, and again, FDA approved for HAE prevention. There are some investigational therapies for hereditary angioedema as well that I'd like to review quickly. Again, exciting times for hereditary angioedema. We have 3 here that I'm going to discuss. We have donidalorsen, which is an antisense oligonucleotide, which reduces prekallikrein expression. There's a phase 3 trial, OASIS HAE, looking at long-term prophylaxis. So far, positive phase 3, and NDA is expected in 2025, any day now. And then we have deucrictibant, which is an oral bradykinin B2 receptor antagonist. There are 3 phase 3 trials going on. Rapid E3, which is for acute treatment, and chapter 3 and 4 for long-term prophylaxis. Phase 3 trials are still recruiting. And then NTLA 2002, which is in vivo CRISPR gene editing of the kallikrein B1. And HALO is the name of the phase 3 trial, looking at long-term prophylaxis and hoping that it's one-time gene editing, one and done. Enrollment is completed in 2025, potential BLA in 2026, and potential launch, if all goes well, in 2027. So exciting emerging treatments as well. So again, just thinking about the currently approved therapy, C1 inhibitor, whether it's human or recombinant, for both on-demand and prophylaxis. Berotralstat, the first oral prophylactic agent, ecallantide and icatibant for on-demand use, and lanadelumab, again, that monoclonal antibody used for long-term prophylaxis. So our treatment, as I've mentioned, has shifted to focus not only on on-demand emergency care, but also positive, proactive, prophylactic management, improving quality of life, and decreasing the impact on our patients' lives. So the OASIS HAE evaluated donidalorsen. Again, that is the antisense oligonucleotide targeting the kallikrein mRNA. And as you can see here, there were substantial reductions in HAE attack rates. A high percentage of patients experienced reduction in their frequency of attacks. And again, this was a favorable safety profile. Most AEs were mild and transient. So donidalorsen is, again, subcutaneous. So it may be well suited for patients who prefer less frequent dosing. Chapter 1 is the trial looking at deucrictibant for prevention of HAE attacks. Again, this is a phase 2 looking at overall monthly attack rates, moderate and severe attacks, as well as on-demand treated attacks. Again, this is the small molecule kallikrein inhibitor. And you can see here that the early results are promising for all 3 of these categories. And so far, the TEAEs have been mild and no serious events or discontinuations have been reported. And this was from 2024 publication. CRISPR-Cas9 in vivo gene editing. As I've mentioned, this is a small scale trial using this CRISPR-Cas9 gene editing targeting that kallikrein B1 gene, which encodes the prekallikrein. And as you can see here, a single dose led to dose-dependent reductions in kallikrein levels, fewer HAE attacks across all dosing levels, and no serious AEs, which has also been a concern from patients thinking about gene editing, and there have been no serious AEs reported. So this is the first trial involving an in vivo gene editing approach in HAE, and this has really the potential for being very groundbreaking and possibly even a functional cure for hereditary angioedema. So we've talked a lot about all of the therapies that we have at our disposal and ones that are emerging, but there are some practical recommendations for improving HAE management that I would like to review with you as well. When we think about our patients with HAE, again, we really want to individualize their treatment plans based not only on their attack frequency, their attack severity, but we've got to take in their preferences, and if the patient wants it, the caregiver's preferences, of course, as well. Providing all patients with access to effective on-demand treatment, as the guidelines point out, for acute attacks, considering long-term prophylaxis for patients with frequent or severe attacks, recommending short-term prophylaxis before procedures known to trigger attacks, and encouraging self-administration so the patients can have not only improved quality of life and reduction of treatment delays, but letting them have as much independence from their disease as possible and feeling more like they have a normal life rather than being strapped down to any particular treatment. So again, shared decision-making. Very important to discuss all of the treatment options available to the patient, ensuring that you, as the prescriber, are aligned with the patient and the caregiver goals, and developing informed preferences, making sure the patient truly understands the discussion and all questions are answered. Talking to the patient about their needs and goals, making sure that the patient has been heard about what they really want. Needle phobia is real in some patients, and this can occur in adults. Some patients do not want the oral. They really want the needle. And so that's a decision for you and your patient to make. And then once this is done, then you can have an informed decision and prescribe appropriate therapy for the patient. And we know that this model not only supports patient engagement, but it helps patients adhere to the treatment plan, and it also increases patient satisfaction with their treatment. So it's also very important to think about equity and inclusivity in hereditary angioedema. We really want to think about health equity in the patient-centered care and our shared decision-making approach. So there is an expanded model of shared decision-making, and this really takes into account not only the patient-centered care, but social determinants of health, as well as health equality. Patients' values and preferences, as well as the scientific evidence, but also those social determinants of health really should be considered. Language barriers, cultural differences, access to specialists, all of these things really have to be taken into account. And reminding us, all of us, again, that individual barriers can be large and can impact not only quality of life, but treatment as well, and access to treatment. So proactively making sure that patients have access to resources, whether it's financial support programs, whether it's patient advocacy groups, whether it's social media, any of those kind of things. It's our role to help as part of the partnership of taking care of patients with HAE to include health equity as well with our shared decision-making. So a really important kind of final piece when we're thinking about the patient action plan and all of the essential components is the importance of a clear, written HAE action plan for every patient. Even in the technological age, everybody has a phone, everybody has a smart device. A written plan is still very important because depending on where the patient shows up, whether they are taking care of themselves and going to an emergency room or an urgent care, maybe they aren't able to communicate as well. Maybe they forgot their device. A written, clear plan is very important. And this should have not only the medications listed, it should tell the patients and caregivers when to seek emergency care, how to administer the medication, what signs and symptoms to look for, and if they're planning for travel, to think ahead of possibly the emergency rooms that may be available to them during their journeys. That actually seems kind of stressful, but it actually alleviates the stress for that travel. So hopefully our HAE patients can either enjoy a vacation or be able to do work-related travel without any increased burden. Now I'm going to hand over to my esteemed colleague, Dr. Nicholas Kalinsky, to review a real-world patient case with hereditary angioedema. Dr. Kalinsky.
Great, thank you, Maeve. That was a fantastic presentation, so we'll get into it. So this was a patient that was seen at our clinic, a 31-year-old female with recurrent episodes of angioedema. Like Dr. O'Connor said, non-pitting angioedema, non-pruritic, no hives, no urticarial lesions. She's been to the ER a couple times for her angioedema. Her episodes occur every 1 to 3 months. It started in adolescence, often with patients that have hereditary angioedema. About 50% have an onset of symptoms by the age of 10, about 100% by the age of 20. This patient had had 2 laryngeal episodes, had never been intubated, which can occur in some HAE attacks. She's had swelling episodes, including her abdomen, face, extremely disfiguring, uncomfortable hands and feet, typically developing over 24 to 48 hours and then resolving over 3 to 5 days. Attacks can be unpredictable, painful, really uncomfortable. And for her, her primary trigger was stress. She had no rash, no itching. And this is a very important part, like Dr. O'Connor was saying, no response to antihistamines, epinephrine, or steroids. She'd been to the ER, urgent care multiple times. They're always treating her with the same thing. And she claimed it never really seemed to make a difference. Next slide, please.
That would increase her stress, wouldn't it, Dr. Kalinsky?
Oh, most definitely. Yeah, she was extremely uncomfortable, extremely stressed. And honestly, she felt desperate. You know, she was worried about having these attacks. It was really impacting her life, and she was worried she wouldn't be able to find a solution to her problem. When we saw her in clinic, her past medical history, she has a history of asthma that wasn't well controlled, chronic rhinitis. She had no known drug or food allergies. She wasn't on an ACE inhibitor. She wasn't taking NSAIDs or any over-the-counter herbals. She is currently not using, she's currently not using any contraception, and she's unsure about future childbearing, if she wants to have a child or not, but her and her husband are not taking any preventative measures to prevent that from occurring. She is on albuterol, so she uses that PRN. She's using a fluticasone nasal spray. Again, she's been to the ED multiple times, but never admitted or intubated, and no official hospitalizations and no history of surgery. Next slide.
Ryan. There we go.
So which of the following aspects of the patient's history would lead you to suspect the presence of hereditary angioedema? The location of swelling during attacks, pain associated with attacks, lack of response to antihistamines, epinephrine, or steroids, and temporal pattern of attacks. We'll give the audience a chance to answer.
Okay, so we have a mixed bag of answers here. So Dr. Kalinsky, what do you think? You want to give us your answer on this? We have a pretty much an even split on our audience poll.
What were the 2 most common answers that you see?
Location of swelling during attacks and lack of response to antihistamines, epinephrine, or steroids.
I think that those are 2 interesting answers. In my opinion and experience, I think it's the lack of response to antihistamines, steroids, epinephrine. That is usually a dead giveaway. We have to think about the signs and symptoms of bradykinin-driven angioedema versus histamine-driven angioedema. If the patient had responded to antihistamines, steroids, and epinephrine, classic histamine-driven angioedema. But hers was different. It never really got better. The only thing that seemed to make it better was time, and a significant amount of time, maybe 5 days or even longer. So that's probably the most important part of her history there.
I often say that if I was teaching emergency room or urgent care personnel about hereditary angioedema, that would be the one point I would want them to remember, is that lack of response.
Certainly.
Okay.
So moving on to her social history, she's not a smoker. She doesn't really drink too much. She doesn't use any illicit drugs. She has no specific environmental factors that seem to trigger her angioedema episodes. Now, this is extremely important. Her mother has a history of asthma and recurrent angioedema that seemed to be worse during pregnancy. Now, we know from Dr. O'Connor's discussion, this is an autosomal dominant gene mutation. So if the mother has it, there's a 50% chance that they could pass it on to their child. It is the SERPING1 gene mutation. So it's very important to kind of think of those kind of things for that autosomal dominant inheritance pattern. And then she has a 7-year-old son with no history of swelling episodes and no prior workup. So he's been asymptomatic. But again, it's important to note that.
And do you think, Dr. Kalinsky, that when someone has asthma and rhinitis and they come in with swelling, that can make people think more of mast cell mediated rather than hereditary?
It certainly could. I mean, I think it's really important to dig into each portion of the history to not get too distracted and pulled one way or another, kind of separate them into certain silos and really kind of address each complaint that the patient has.
Yeah.
So she had a negative and normal exam otherwise. Physical exam was largely normal. There wasn't any swelling at the time of the visit, and so largely normal physical exam.
Right.
What type of testing would you order for this patient? So C4, C1 inhibitor level, C1 inhibitor function, a genetic test, an allergy test, a CT scan of the neck and the chest.
Give it a couple more seconds. Okay. So it looks like we have an even split. We have 50% on C4, C1 inhibitor level and function, and 50% say go straight for the genetic test.
I see. Okay, so I think that both of those could definitely help aid in the diagnosis, but I'm usually leaning towards what is the easiest and most accessible for the patient, and probably that first line test that I would order. I would typically go with A, which is C4, C1 esterase level, and C1 esterase function. The patient came in with asthma. She could potentially have allergic asthma. She has some rhinitis symptoms. An allergy test could be a reasonable part of that. Get a spirometry. We're going to look at lung function, but I don't know that I would jump immediately to a genetic test. I think first it's reasonable to start with the blood work first.
Yeah, and we saw in that algorithm as well from the guidelines, right, that what you're saying is absolutely true. And the cost, we have to think about the cost of the test. If we can get our answer, as you mentioned, with the C4, C1 inhibitor level and function, we may not have to do the costly genetic test until later, right?
Correct, for sure.
Now, what about that CT scan of the neck and chest? What do you think about that, Dr. Kalinsky?
So I have seen a tumor actually cause angioedema and swelling of the upper extremity, usually unilateral, could be bilateral. I mean, it's important to keep that in your differential. I have ordered that type of test for patients with some sort of swelling, but generally the presentation I think is different. And it's a good thought. You got to keep those kind of things in your differential, but I think it is unlikely in this patient.
Right. Yeah, always need to think of those kind of things. But I think in this case, A is the correct answer for sure. Any other thoughts about the genetic testing or anything on that, Dr. Kalinsky?
So I've ordered the genetic test. It's important knowledge to have, knowing how to order it, under what conditions to order the test. If the blood work comes back and it's not exactly clear, sometimes the patient doesn't read the book and behave exactly how they're supposed to. And so I think it's a reasonable test to order if you feel like you need to order it. We have to remember too that not every patient with hereditary angioedema has that type 1 or type 2. Sometimes it's HAE with normal C1 esterase, where the lab work may come back normal. Again, like you mentioned, if you have that high index of suspicion, you may need to get that genetic test that can help you confirm that factor 12 gene mutation. I believe that's the most common one, present in 25% of those individuals. And so I typically use Invitae. It's very easy. I would encourage everyone to become familiar with that genetic test service. I think that it's works well.
And depending on where a provider is taking care of these patients, they may need to familiarize themselves with what may work for them. But most anyone can send to that lab, I have found as well. And just you had mentioned, about the genetic testing, and I think obviously if we're thinking it's HAE with normal C1, we also have to be good stewards, right, of unnecessary testing, unnecessary costs. So I think you make really good points there.
Definitely. So here's the lab results. So kind of look at this and digest it for a second. But at the top, you've got C4 protein level, C1 inhibitor level, and then C1 inhibitor function. And you can see that the C4 is low, the C1 inhibitor level is normal, and the function is low. So keep that in mind. So we've got low C4 and low function.
Okay.
So based on the lab results, what is your diagnosis? HAE type 1, type 2, type 3, or HAE with normal C1 inhibitor, or allergic or idiopathic angioedema?
I'm going to give it a few more seconds. Okay. Well, we have 20% say HAE type 1, 40% say HAE type 2, and 40% say HAE with normal C1. Nobody thought it was allergic or idiopathic angioedema, which makes me extremely happy. When you're really repeating points and making sure that makes me happy. So Dr. Kalinsky, what would you like to tell us about this? What are your thoughts?
Could you go back one slide?
Absolutely, to those lab results. Yes.
Yeah. So this is something that, we just really kind of need to commit to memory. Whenever somebody has a low C4, a normal level of C1 inhibitor, but a low function, that is type 2.
Mm-hmm.
So how I remember it is that if it's going to be low across the board, so low C4, low C1 inhibitor level, and so low C1 inhibitor function, that's going to be a type 1. Now, if everything is normal across the board, that's going to be HAE with normal C1 esterase, where everything's going to be normal, including the C4 and the function. Does that make sense?
Oh, that makes absolute perfect sense. And I remember too that we used to get questions when we were pimped on rounds. What if you could only order one thing? What would you order? And they would say a C4. So do you have any comments on just ordering the C4? Or do you think now that we have accessibility to the C1 inhibitor level and function, we should do all three? I think you might be frozen, Dr. Kalinsky. So I'll answer my own question and just say that since we have the availability and they're fairly inexpensive, we would definitely do all of them. Dr. Kalinsky, are you back? You froze for a moment. There you are.
I think I'm back. Am I there? Yeah.
There you go. Go ahead, and I'd love to hear your comment.
I was going to say that I would do them all. If I was going to take a board exam, the first answer is usually a C4 as a screening test. But as far as what we do in clinic and in the real world, you're going to do them all, C4, so inhibitor level and function.
One day the board exams will actually reflect what we do every day. That's my dream. Okay, so we'll move forward now. Okay.
The patient is diagnosed with HAE type 2. What type of on-demand treatment would you prescribe for the patient? We've got C1 inhibitor, icatibant, ecallantide, or sabrelistat.
They don't make the drug names easy.
Sabrelistat. There we go.
I do the same thing. I did it earlier on one of my slides, and I say the words all the time. But when you're saying them all, it can be a tongue twister. Okay, so we're getting still some answers, so a couple more seconds. Okay, so it looks like the majority, 50%, or I guess half, 50% want D, sebetralstat. I stopped and thought about how to say it. And then 25% want icatibant and 25% want ecallantide. Nobody wants C1 inhibitor. Dr. Kalinsky, any comments on that?
I think this is an interesting question. If the patient was pregnant, I think that A would be an appropriate answer for an on-demand treatment, but she's not. She was seen initially some time ago before option D was out. And
Mhm.
so she ended up going on icatibant is what she ended up
Oh, sorry. I went
going
forward
on.
better. Yeah. So she went on icatibant?
Yeah, she went on icatibant, but now she's actually switched to D. So
Okay.
it's a new development as last week actually. Yeah, last week.
So I have a question
Do you
for you.
have an opinion on that?
How did you come to that decision? I'd love to hear about your conversation with the patient in making that switch, because that sounds like a shared decision making discussion.
Right. I think that it's important to let each patient know about new developments as far as different therapeutic options. When it comes to a prophylactic medication, if a patient is on cruise control and they're doing great, I don't know that I would come in and try to reinvent the wheel and tell them about a new product if they're just doing great, they're having no attacks. But I think these on-demand rescues are different.
Mhm.
It's the delivery mechanism. It goes down to efficacy, patient preference, safety, side effects. There's all these different factors. And so I let the patient know about the new product and I offered it to them as something that they could consider. If you're familiar with it or if you've seen it before, it comes almost like in a pack. It looks like a pack of gum that you would push through foil. It
Mhm.
seems to be very easy for the patient to carry around. And so it was a shared decision-making moment. And the patient ended up choosing to switch.
Yeah. I often have patients will come in and they'll have read or learn about a new treatment, and they'll come to me with it even. So HAE patients, once they're diagnosed properly and on treatment, sometimes they can really be savvy on what's coming. Those emerging treatments, for example.
Definitely.
Okay.
All right, so on to the next question. Which of the following would you prescribe for prophylaxis? So we've got C1 inhibitor, danazol, lanadelumab, or betralstat.
Okay. This might be the first one where we really have a majority of answers. So 80% said C, lanadelumab, and 20% said C1 inhibitor. So when you talk about this, Dr. Klinsky, I want you to also let us know about the discussion you had about them not using birth control and that discussion. I'd be very interested to hear how you discussed that with the patient and her spouse.
Right. So, I think that um, it's an important point to make, knowing that some of these drugs, as far as getting them approved, prior authorizations, I like to get it right probably the first time. And the patient wasn't necessarily trying to prevent herself from getting pregnant, and she was open to having more children. If you're not trying to prevent getting pregnant actively, then you're basically trying to get pregnant, I think, for some people, depending on what's going on. So I chose A. I put her on C1 inhibitor replacement. I think option C is an incredible option. It just depends on the patient. You got to have that discussion with them, letting them know, like, hey, if you were to get pregnant, we would have to switch you, or it would be recommended under the guidelines at least to consider switching you to C1 inhibitor replacement. And it was that discussion that took place that ultimately made our decision to go with A over C.
Right. Because it seemed like she said she was unsure. So it seems like they may have been a couple that was just, well, if it happens, it happens. So that makes sense that C1 inhibitor would be the answer. But I can completely get choosing C as well, especially when you think about the efficacy results that we showed on those slides. So, all
For
right, thank
sure.
you for that. And I'm going to try to advance these sticky slides. There we go. Okay, so
All right, so for her, we chose the on-demand treatment, the bradykinin antagonist. We put her on prophylactic treatment with C1 inhibitor replacement, given her age and the things that we just discussed, but primarily thinking about if she was going to be pregnant and what the guidelines at least recommend for pregnant individuals. Other recommendations, so we gave her a nasal spray that was better in some ways, in my opinion, than the one that she was on. She was put on ICS LABA for her uncontrolled asthma. And then we also tested the sun. And so, like you said in your presentation, and it's an extremely important point to make, it's an autosomal dominant gene mutation, hereditary angioedema. That means that there could be a family history, maybe 75% of the time. 25% have those de novo mutations. But we know because it's an autosomal dominant gene mutation, that child has a 50% chance of inheriting that gene mutation. So we did test the son as well. We did a C4 inhibitor level and function.
And I was just going to mention with the control of her chronic rhinitis and her asthma, not only are you helping those chronic conditions, but you're also decreasing her stress of having other uncontrolled illnesses, right? So that stress as being one of her top triggers, you were helping her in more than one multifaceted way, right?
Most definitely. You have to treat the whole patient. Don't just get so pigeonholed into one individual thing. Remember that, especially as allergists, immunologists, many of us were internists or pediatricians first. So we really need to think about the whole patient.
Yep. Right. Thank you for that.
So her HA attacks, this is a follow-up visit at 6 months, were well controlled on C1 inhibitor prophylaxis, but then she had a change in her insurance and she was dropped off basically on getting this medication. There was poor communication with the office. The office wasn't aware that she wasn't getting the medication. She was having some breakthrough attacks, but then not letting us know about those attacks. And she ended up going to the ER and urgent care multiple times, and she's going through all her icatibant very, very quickly. So she's using multiple doses all in one day. And now she follows up with us in clinic, and we learn of these things. So with some of the medications for hereditary angioedema, just overnight or very quickly, it can be hard to get some of them approved with the insurance company. And ultimately, we ended up putting her on danazol. Her symptoms and attacks were happening so frequently that we were worried if we continued to wait that she might have a life-threatening laryngeal attack, and potentially, again, it's life-threatening, so she could die from one of those. So danazol is not at all, I don't think, anybody's favorite first-line option, but we put her on danazol and we advised her to take measures to prevent pregnancy while we waited until we could get her C1 inhibitor approved.
I think with her history of most of her attacks being laryngeal and abdominal, this was a great option. I mean, what else could you do? Unfortunately, with these expensive medications, it doesn't happen overnight. So very interesting. How did she tolerate that?
She actually did better on the danazol. I don't have as much experience with danazol as I do with some of the other products because they're so great. Side effect profile is so clean with many of them, but she ended up doing okay on the danazol. But we'll see. The story gets a little deeper here in a second.
Okay. Here we go. I'm pushing. There we go.
All right. So with all the attacks that she had, she'd been to the ER and urgent care multiple times, going on multiple rounds of prednisone, often extended courses. We know that wasn't going to work, but that's what was happening. We didn't know about it. And then also with danazol, a side effect can be weight gain. So it turned out she gained about 40 pounds in this time period. So this is a nightmare for many of us treating hereditary angioedema.
Mm-hmm.
When we had the drug approved again, it was for her old weight. Now it's a weight-based dose. So once she was on it, she had improved some, but she was still having attacks much more frequently than what she was when she was previously controlled before she dropped her insurance or changed her insurance. And she's again going through all her rescue medication. So she comes back in and she sees us. We decided to recommend a higher dose C1 inhibitor. She was so well controlled on that. We felt like the explanation for her increase in attacks was due to her weight gain, either that or a kallikrein inhibitor. But the patient was also aware of an oral prophylactic medication as well, and that's what she had chosen at that time. She did get better on the oral prophylactic medication, but again, those attacks continued to occur over the next 3 months. And ultimately, she ended up going back on the very first medication that controlled her, which was that higher dose C1 inhibitor.
So a complicated path for this patient, which is not atypical, right? So it's another reason why the shared decision making is so important, and keeping in touch with the patients. And also, I think educating the emergency departments and urgent cares in your local area as much as you can to coordinate care. So great job on that. All right, so I'm going to just review some key points before we get into questions. Again, we're talking about hereditary angioedema. Early diagnosis is essential. This not only ensures appropriate treatment, but it helps improve disease outcomes for patients with HAE and improves their daily quality of life. We talked about the first-line diagnostic tests, including C4 level, C1 inhibitor level, C1 inhibitor function. And if these are normal, but you really still have a high index of suspicion for hereditary angioedema, consider the genetic testing for HAE with normal C1 inhibitor. And as Dr. Kalinsky did very well with this patient, treatment should target reduction of disease impact on patients as well as their caregivers, and on-demand therapy should be for all patients and prophylaxis as needed. We have reviewed the HAE treatment landscape and how it continues to evolve. We are having increasing options for on-demand treatments of our acute attacks, as well as increasing options for prophylaxis to reduce the attack frequency and severity. But overall, shared decision-making HAE management should be personalized, based not only on attack frequency and severity, but also on patient preference. So we are ready now, Dr. Kalinsky and I, to take some questions. And thank you very much, Dr. Kalinsky, for a great patient case. We have one question in the chat. I think I'm going to click on that. I can't see it. Can you see it, Dr. Kalinsky?
I'll check. So I see one question from early on. What are key considerations for HAE management that are specific to young children and adolescents?
Okay. So I guess if this patient's son ended up with hereditary angioedema, walk us through what you would have done for him.
Sure. So I think the biggest thing that's going to determine what you're going to put the patient on is probably age and indication and what's actually approved down to what age. If I had it my way, and if I was just looking at the product and delivery, age aside, as far as what's in the package insert, I would want something that's going to be extremely convenient and easy for the patient, preferably something that's not very painful, probably where the dosing frequency isn't multiple times a week, but maybe every other week, once a month. So I would go over those kind of things with the patient's family, but those would be some of the things that I would think about, ultimately understanding that it's going to be the drug that's approved down to the age of the patient.
Sure, you always have to take that into consideration. But also that's a perfect time where you really have to take in the caregiver's perspective as well, right? We talked about the caregiver fatigue, caregiver burden. And so as you mentioned, it's really going to be a longer discussion. But I would agree with all the points you made, and I really have nothing to add. I again see something's in the chat, but I can't view the question. So I don't know, Dr. Kalinsky, can you see it?
Yes, I can see it. It says,
Right.
how do you approach care for a patient who is planning to become pregnant? What are the treatment options during pregnancy?
You know, I actually have a slide on this. I was hoping somebody would ask if I can forward this slide. There we go. Dr. Kalinsky.
Right. And so you can see there at the top, you have C1 inhibitor. It's an IV product for on-demand and short-term prophylaxis. That is the preferred option in pregnancy. And then you've got another C1 inhibitor product as a prophylactic product that's given subcutaneously. That is the preferred option. So really, this is what you would want to do ideally as far as guideline-driven recommendations for prophylaxis and then also on-demand. It would be both C1 inhibitor replacement.
Wonderful. Thank you very much. Well, I know we are a few minutes over. So I would just like to say thank you, Dr. Kalinsky. It's been wonderful doing this presentation with you. I certainly have enjoyed it, and I hope that our audience has as well. So thank you very much.
Yeah, thank you so much, Dr. O'Connor. As always, it's been a pleasure, extremely educational, and so thank you.
Thank you very much.